A very good evening to one and all present here today. I would like to welcome all our esteemed faculty members, our delegates who have joined us online, as well as my fellow colleagues for this academic fiesta hosted by Astellas today. Today evening, we are gathered here for an international speaker program, Outcomes and Recent Advances in Treatment of Relapsed Refractory FLT3 Mutated AML. It is my pleasure to invite Dr. Tulika Seth, who is our program director for the day. She's Professor Clinical Hematology, All India Institute of Medical Sciences, New Delhi. Ma'am, I would like you to take the session through and introduce our international speaker as well. Over to you, ma'am.
Thank you. Thank you so much. So it's a very exciting international speaker program. We have a very eminent physician who's contributed immensely to the field of acute myeloid leukemia and FLT3 AML. And we also have a plethora of national experts who will take us through the situation in our country. I'll just run through the program that we're going to be having. So I'll do a small context setting. Then we have AML discussion by Dr. Amrita Ramaswamy. Dr. Amrita Ramaswamy is a consultant at Max Super Specialty Hospital, Shalimar Bagh, New Delhi. Then we have our eminent speaker, Dr. Jessica Altman. She's Professor of Medicine, Hematology and Oncology at the Feinberg School of Medicine, Northwestern Medicine Developmental Therapeutics Institute in Chicago. And she has authored numerous publications in the field, as well as she's the chairperson of the Leukemia Steering Committee at NCI, an active member of NCCN. We all follow their guidelines. She's also been, she is also currently a panel member for AML and CML at NCCN and vice chair of the AML panel, and a facilitator for the harmonization of AML, CML, and ALL guidelines. So we're very honored to have you here. And we then have a case-based panel discussion, which is going to be moderated by Dr. Sarita Rani Jaiswal. And in that, we're going to have several other panelists, myself, Dr. Amrita Ramaswamy, and Tejaswini Ved. And we have a second panel discussion with Dr. Manisha. And Dr. Manisha is Consultant Hematology Bone Marrow Transplant Unit, Medanta MedCity, Gurugram. And in her panel, there's going to be Dr. Jessica as a panelist, Dr. Priyanshi Pachauri, who's from Fortis Noida, Dr. Padmaja Loki Reddy, who's a friend and colleague from Hyderabad Apollo Hospital, and Dr. Nivedita Dhingra, who's Associate Director, Hemato-Oncology, BMT Max Hospital, Patparganj. So that's a brief run-through of the program. So I will now give a brief context setting. So can I have my slides, please? Thank you. So this is a small overview that was requested. Of course, everybody who's going to be joining us today is well versed with this. These are the disclaimers. Next slide, please. So FLT3 mutations are present in approximately 30% of AML cases. And we know that this, since they were recognized, we know that this leads to poor outcomes and a high due to the high rate of relapses. And there's a need for hematopoietic stem cell transplant for these patients, but many times transplant is not possible due to many factors. And when patients do relapse, then using multiple lines of very toxic chemotherapy often still has led to poor results. So when the FLT3 inhibitors first came in, it was really a game changer. And though here it shows midostaurin is there, we actually got midostaurin quite late in India. We had sorafenib, and we would use that, but sorafenib was very difficult to manage in many patients due to toxicity. When midostaurin came in after the ratified trials, that was really the only thing that we had. And though it was good, but patients often would develop resistance and relapse. So when the second generation FLT3 inhibitors have come in, it's definitely added to our armamentarium, and we have now a lot of other options for patients So it's really been quite heartening to see the progress in the field. Next slide, please. So in the current NCCN guidelines, we know that for the relapsed and refractory patients, there's only one agent that we have that has grade 1 evidence, and that is gilteritinib. So that's one of the major drugs that we'll be talking about in today's discussion. There are other options that are there, but this is really, really important. Next slide, please. And in this, you can see in the current guidelines, even though we know that patients with FLT3 ITD mutations, they have a poor result, but because we now have effective treatment, they are now grouped into the intermediate group. So treatment also has a very important prognostication, and these patients will only be in the intermediate group if they are appropriately treated. Otherwise, this is a adverse risk marker. So I think that's the last slide I have. Perfect. So with that, I now move on to first invite Dr. Amrita, who will be giving a brief overview of acute myeloid leukemia, the Indian perspective. And as I had said, Dr. Amrita is the principal consultant hematology and stem cell transplant at Max Super Specialty Hospital, Shalimar Bagh, New Delhi. Over to you, Amrita.
Ma'am, I think Dr. Amrita has not joined in yet. Maybe what we can do is we can move on to the next session, and maybe we can come back to Dr. Amrita's session.
Perfect, perfect.
Yeah.
Okay.
And ma'am, I would also take this opportunity to share with everyone on this panel as well as in the attendees out there that this particular event was specially designed in a way that all women hematologists all across India would come together and discuss about the recent advances in treatment of FLT3 positive AML. So I would like to thank each and every one of you for accepting this invitation and also respecting our idea and thought process of driving this. Thank you, ma'am.
Thank you so much. And with that, I invite our special speaker and guest for the evening, Dr. Jessica Altman. And she will talk about the outcomes and recent advances in treatment of relapsed and refractory FLT3 AML. And as I introduced her, she is a very important person in the field of FLT3 AML and has contributed greatly to this field, and we're honored to have her. Over to you.
Wow, thank you very much for the absolutely beautiful and humbling introduction. It is truly my honor to be here with all of you. I'm going to try to share my slides, and please let me know if anything does not come through properly. So again, thank you for being here. It's especially an honor to join you with a group of phenomenal women who have made major strides in the field. So thank you all for including me. As mentioned, I currently work at the Robert H. Lurie Comprehensive Cancer Center, Northwestern University, and have been really lucky to focus a lot of my clinical career and translational work in early phase clinical trials on FLT3 mutated AML. Sorry. Here we go. I'll give you a moment to look at this disclaimer. And to let you know that I'll be discussing leukemia with a focus on FLT3 mutated disease, the utilization of gilteritinib, some brief comments about resistance to gilteritinib, and I'll intersperse some discussions about future directions. This conversation will really be case-based, and I look forward to any comments and questions at the end. So I'm going to start with this first case. It's a 75-year-old woman, history of arthritis, high blood pressure, gastroesophageal reflux disease, history of a cerebral aneurysm, who presented to our emergency room in January 2020 with shortness of breath and chest discomfort. In the emergency room, because of the shortness of breath and chest pain, the reflex testing was a CT protocol for PE. There's question of whether or not this was a PE. What we'll learn is that this is actually likely just white cell infiltration into our lung vessels. Her exam was notable for pallor. She looked comfortable at rest and was otherwise unremarkable. And she had a performance status of 2. So fortunately, in addition to the CT scanning, the emergency room got some blood work with a white blood cell count that was markedly elevated, 196,000, a hemoglobin of 7.2, platelet count of 18. And her differential revealed 84% blast. And you can see this smear on the side over here. Her creatinine was 1.06. She did not experience hyperkalemia, and she received emergency treatment with IV fluids, allopurinol, and hydroxyurea. So bone marrow biopsy was conducted the following day, revealing acute myeloid leukemia involving over 90% of a hypercellular bone marrow. Her bone marrow was nearly 100% cellular. Cytogenetics were normal female karyotype, and her molecular studies revealed a FLT3 internal tandem duplication mutation, the NPM1 mutation, TET2, and a DNMT3A mutation. So this patient placed great value on independence and time out of the hospital. She, through our conversations, initiated therapy with azacitidine and venetoclax. And after 1 cycle of treatment, her disease entered a complete remission by morphology. Her NGS revealed continued presence of the FLT3 internal tandem duplication mutation and the NPM1 mutation. So I think the real question was, when we were talking to her, what should we expect from azacitidine and venetoclax, especially in a patient with FLT3 mutated disease? So if we look at all comers with a newly diagnosed AML, this data is well known to all of you, I believe. And with a median follow-up of 20.5 months, an overall survival with azacitidine and venetoclax of 14.5 months compared to about 9.5 months, which was the basis for FDA approval. But when we look specifically at those individuals with a FLT3 mutation, the median overall survival for all FLT3 mutated patients is 12.5 months. But when we break things down to those with a FLT3 ITD versus the tyrosine kinase domain mutation, the FLT3 ITD patients only experience a median overall survival of about 10 months versus nearly 20 months with those with a FLT3 TKD mutation. And so really those FLT3 TKD mutant patients are really what's driving the benefit. And there's a really limited benefit for the ITD patients, unfortunately. So to get back to our patient, she continued therapy for a year with cycles given approximately every 4 to 6 weeks as her counts would tolerate. But after 1 year of therapy, her counts did not improve as robustly as they had the cycles before. And while her goals were quality of life and extending her survival, I was able to have her agree to a repeat bone marrow biopsy, which, not surprising, revealed recurrent AML. So I think one of the questions is do you recheck a mutational panel, and what do you do? And I don't know that we have the ability to kind of poll the audience, but the options that one could think of at the time for the treatment of recurrent AML in this patient include daunorubicin, cytarabine, and midostaurin. Again, she was an older woman who placed great value on her quality of life. Another option, gemtuzumab ozogamicin for CD33 positive relapse disease. Gilteritinib, a menin inhibitor, given the NPM1 mutation, or switch the azacitidine to decitabine and continue the venetoclax. Those are the possibilities that were considered. So what happened to our patient? We rechecked her mutational analysis. Both the FLT3 ITD and the NPM1 mutation were still present with a VAF of 10% each. She proceeded with treatment with gilteritinib as per the FDA approval and standard of care. She had normalization of her blood counts, maintained an excellent quality of life. She again opted not to be followed with just follow-up bone marrow biopsies and was followed clinically instead with blood counts. And after 15 months of therapy on gilteritinib, she developed neutropenia, and a bone marrow evaluation revealed recurrent disease. I'm going to take a step back and discuss really where we've been since 2017. We've made remarkable improvements in the armamentarium of treatments for adults with acute myeloid leukemia. And as my colleague, Dr. Seth, already mentioned, there have been multiple approvals that have occurred since this time, including midostaurin, gilteritinib, and other targeted therapies targeting the IDH1 mutations, IDH2, and now in the US, the approval of the first menin inhibitor. And there are multiple questions that kind of still exist. Will we be looking at targeted chemotherapy sparing combinations for newly diagnosed AML patients? What questions do we have in terms of FLT3 maintenance options? I think some of these questions we may actually try to address in the cases we have later today, including optimization of stem cell transplant based on MRD. So these are the questions that we think about in our institution and the research practice. So despite progress in the development of newer agents and combinations, there's significant unmet need in the US and across the world. But based on some US data that I wanted to share with you, there of a relatively large patient population of 5,000 patients with newly diagnosed AML and nearly 1,000 patients with relapsed and refractory disease between 2016 and 2022, which is when we had the time frame when we had access to a lot of these targeted therapies. A large portion of patients, nearly a third of relapsed and refractory patients, received no treatment for AML in the United States, and nearly 40% of newly diagnosed patients did not receive any treatment. So there's clearly a lot more work that needs to be done on a societal level in education of community practitioners and trying to get folks appropriate treatment. So a little bit deeper dive into the FLT3 mutation. This is still the most currently mutated driver gene in normal karyotype acute myeloid leukemia. It is mutated in about 30% of folks with newly diagnosed AML, frequently associated with a high white blood cell count, frequently associated with the NPM1 mutation, and more commonly seen in younger adults, though we do see it in older adults as well. It has traditionally been considered an extremely poor prognosis, as Dr. Seth mentioned already. And if you look at data from Froehling from 2002, the presence of the FLT3 mutation compared to those without the FLT3 ITD specifically, there's a significant decrease in the percentage of adults who are alive. Dr. Papa Emanuel in her New England Journal from 2016 also corroborated this information about the presence of the ITD mutation impacting overall survival, especially when we look in the patient population with an NPM1 and DNMT3A mutation. You may have picked up that one of the cases that I presented, the patient had this characteristic triplet of mutations of NPM1, DNMT3A, and FLT3. And the FLT3 appears to be what drives the change in prognosis in this NPM1, DNMT3A mutated group. So FLT3 inhibitors are well known to our group, and I'll just note that the type 1 inhibitors, which bind both the active and inactive conformations, are active against both the ITD and TKD mutations, whereas the type 2 inhibitors, which include quizartinib, are active against only the ITD mutations because they're active only in the inactive conformation. The type 1 mutations, which we're going to be able to talk about today, include midostaurin and gilteritinib. Okay, so next case. It's an 80-year-old female that I just met recently. She, however, presented to another institution in 2024 with fatigue. She was diagnosed with AML with a FLT3 ITD mutation. No NPM1 mutation was present. She declined clinical trial participation, was treated with azacitidine and venetoclax. Her disease entered a complete remission, MRD positive, but still with the FLT3 ITD by PCR. So She was about 79 at the time. She received only one more cycle of therapy. Then she discontinued treatment in an MRD positive state because she didn't like how she felt on treatment, is the story that she told me. In June, when I was on service, she presented to our hospital with fatigue and very elevated white blood cell count with 80% peripheral blasts. And so this becomes a question similar to the cases that I presented earlier, is what is your approach to this patient? She only got 2 cycles of azacitidine and venetoclax. Would it be reasonable to restart that? What about best supportive care and hospice alone, or the initiation of gilteritinib? So the Admiral trial really gives us a lot of comfort and excitement about the use of gilteritinib. To remind everyone, these were adults with relapsed and refractory AML. And either were required to have the FLT3 ITD or TKD mutation. And we pre-selected patients to either be assigned to high intensity or low intensity, meaning that we would be able to compare the adults who received gilteritinib who would have been assigned to a low intensity therapy, and the adults who received gilteritinib to those who would have been assigned high intensity therapy to see if there were any differences. The primary endpoints were overall survival and a combination of CR/CRh rate. This was a remarkable study, and noted that of the patients who received gilteritinib, 34% achieved a CR/CRh, with 21% of patients having a true CR. And that compares to what salvage chemotherapy achieved, with a CR rate of only about 11% and a combined CR/CRh rate of only 15%. And remarkably, an improvement in overall survival, with a 12-month median overall survival in the gilteritinib arm of 37%, which compares favorably to those who received salvage chemotherapy of 17%. We think about the median overall survival rate with gilteritinib of 9.3 months versus salvage chemotherapy of 5.6 months. And so this clearly resulted in an improvement for our patients. Other things to think about with gilteritinib when we think beyond just the survival rate is the patients who receive gilteritinib randomized to that arm, there was an improvement in the transfusion burden. So 80% of patients randomized to gilteritinib were transfusion dependent, and 35% of them became transfusion independent. In addition, there was an increased rate of transplant with a goal of curative intent, where 25% of patients on the gilteritinib arm proceeded to transplant, comparing to 15% in the standard arm. And likewise, even when we censor at the time of transplant, the improvement in overall survival is maintained, which I think shows a lot that it's not just the stem cell transplant that is driving the improvement in overall survival. And importantly, if patients are able to restart gilteritinib post-stem cell transplant, there is an improvement in survival with the addition of gilteritinib post-transplant. Okay, so what happened to our woman? Remember, this is the 80-year-old lady who received only 2 cycles of aza-ven. She was immediately treated with hydroxyurea, IV fluids, tumor lysis syndrome monitoring. Her white blood cell count nicely decreased with hydroxyurea. We had continued conversations regarding options for her. She decided to proceed with gilteritinib monotherapy. She had excellent tolerance, was discharged home. And so what counseling would we provide to her regarding toxicity, and what monitoring should we be doing? When we look at the Admiral data, nicely shown in the New England Journal article, are the treatment emergent adverse events in this table. And I just kind of want to summarize them for you. The most common fatal treatment emergent adverse events seen with gilteritinib are listed on the right side of the chart, with the occurrence of pneumonia in 3 patients, intestinal perforation in 2, and septic shock in an additional 2 patients. We worry with targeted therapies, and the FDA in the US, and I'm sure it's true elsewhere, has really high scrutiny about the concern for QTc prolongation. and only 5% of patients had QTc prolongation that we thought might be possibly related to gilteritinib, with only one patient with a QTcF of greater than 500. Dose reductions due to this were only required in 2% of patients, 6 patients total on the study. And the most common SAEs related to gilteritinib or febrile neutropenia, increase in the transaminases. And the mortality rate on the gilteritinib arm at 30 days is 2% versus 10% in the salvage chemotherapy arm. And at 60 days, under 8% with gilteritinib versus nearly 20% with the salvage chemo arm. So when I'm thinking about treating my patients with gilteritinib and counseling colleagues in the community, I like to think about a couple of adverse events that occur at grades 3 or higher. And those include really just changes in the blood counts, anemia, febrile neutropenia, and thrombocytopenia at approximately 12 to 20%. The recommended dose, as all of us know, is 120 milligrams daily. It's dispensed as 40 milligram tablets. And so 3 tablets, though dose reductions to 80 milligrams are allowed due to toxicities. Doses of 80 milligrams appear to inhibit FLT3 well. Doses less than 80 milligrams, it is not clear. I included this slide for your perusal, so you'll have it if useful for you and your nurses in terms of the monitoring that's done. So prior to treatment, checking blood counts as CMP, including a CK, because there can be elevations of creatinine kinase with gilteritinib, and an EKG. And then the weekly blood work and EKGs are shown for the first month of therapy, and then what we do at the second month and beyond. But however, I encourage all of us to use our clinical judgment. As we know, these are patients with relapsed and refractory AML, and they may have significant count abnormalities and should not just be followed weekly if they require more close monitoring than that. This slide was taken from a colleague of mine, her ASH presentation, Dr. Eunice Wang, who is also a dear friend and a wonderful colleague in the FLT3 world. And I really like this slide, and I like sharing it. The toxicities that occur in our patients, we think about in a couple of categories: the count abnormalities that I mentioned, but where we can see liver abnormalities, fever, posterior reversible encephalopathy syndrome, which we call PRES, differentiation syndrome, myalgias, and edema. So the question becomes, well, what do I do if these occur, and what do I do if they occur early versus late? And so ideally, the goal in the first 6 cycles of therapy is to try to continue treatment if the toxicities are not severe. We can also continue for mild to moderate renal impairment and mild to moderate liver impairment, and mild differentiation syndrome that responds to treatment. However, if patients experience severe differentiation syndrome with life-threatening complications despite the utilization of steroids, or significant LFT abnormalities and pancreatitis, or prolonged QTc that is significant, these are things that require us to hold and then restart at lower doses. The one entity that requires permanent discontinuation of the drug is posterior reversible encephalopathy syndrome, but it is incredibly rare. It occurs about 1% of the time. And if patients are not responding after 6 cycles of therapy, not just not responding in terms of what we're seeing in the bone marrow, but are not having any clinical benefit, then these are patients that I would consider moving on to an additional treatment algorithm. I've also included this as our recommended management of toxicities related to gilteritinib, and I'm not going to spend the time going through each and every one of them. Most of it we've discussed, and I really have it here just for reference, because I'd like to turn to some of the real-world evidence that I think we'll all find interesting, as there's been more utilization of gilteritinib across the world. So I'm going to talk about a couple of countries, Korea, Turkey, Israel, and Italy, and then I'm going to turn to a little bit of US data that I know better. So the real-world evidence from Korea, this is a single center from Seoul, the National University Hospital. They treated 10 patients over the course of just over a year. 9 of the patients had the ITD mutation, 1 patient had a TKD mutation, and 8 of the 10 patients had a partial remission or better. As we saw in Admiral, the time to best response was on average 2 months. 3 of the patients didn't have enough of a response, and 3 patients experienced grade 3 hepatic adverse events. For patients less than 60, there were 4, and 3 of them were able to go to stem cell transplant, and 2 remained on gilteritinib maintenance. Unfortunately, this was presented just in an abstract form, so I don't have more data yet, but I'll be interested in the panel discussions if we have time to discuss in more detail. Likewise, I have a little bit of data from Turkey as well, where they treated 17 patients and claimed an overall response rate of 100%. They had 1 patient who experienced significant thrombocytopenia that led to permanent treatment discontinuation. Again, not clear to me if that was disease recurrence related or treatment related and couldn't be improved with dose modification. They also found that patients with peripheral edema had a significant higher risk of death compared to those without peripheral edema. My thoughts on this, and again, I wasn't able to get too much more information, but my thoughts on this were these patients experiencing differentiation syndrome, or were these patients with who had a low albumin and were just more ill, and therefore, because they were more ill, were not able to attain as much of a benefit. So also kind of really interesting questions. Then we get to Israel, where they treated 25 patients with relapsed and refractory AML from 6 academic centers. 80% of the patients had been treated with prior intensive induction therapy. And this is a little bit more of a modern group, because about 40% had received a prior tyrosine kinase inhibitor, likely midostaurin. 12 patients achieved a CR, so 48%, really similar to what we see with Admiral. And with a median overall survival of 8 months. Also very much mirrors what we have seen in Admiral. The patients who achieved a CR, as expected, had an improvement in overall survival compared to those who didn't. And prior TKI did not affect overall survival. Again, we'll echo some of this data a little bit later in the talk. Age and ELN risk matched comparison between patients treated with gilteritinib and intensive chemotherapy demonstrated a 50% response rate in both groups, with a slight improvement in median overall survival of 10 months compared to 7 months, and those who received gilteritinib compared to their matched controls. We don't have much discussion about the difference in quality of life, but I would hazard to say that those who received gilteritinib had not just a slight improvement in overall survival, but likely an improvement in quality of life compared to those who had the chemotherapy. And finally, we turn to the largest group, which was most recently presented at ASH. This is the Italian real-world experience with nearly 150 patients with relapsed and refractory AML treated with gilteritinib monotherapy. These were patients where the majority had the ITD. A couple patients had both an ITD and a tyrosine kinase domain mutation, and 8% had the tyrosine kinase domain mutation alone. 26% of patients received gilteritinib post-transplant for relapsed disease. 21% of patients were able to use gilteritinib as a bridge to proceed with transplant. And 50% of patients, again, the same numbers that we've seen in Admiral and in the Israeli data, 50% of patients achieved either a CR or CRI with a median overall survival of 10.6 months. So all very nice that what we're seeing as real world evidence mirrors the clinical trials. That's not always the case based on my experience. So I want to turn to 2 US studies. The first one is a study that we led at my center, 11 US centers, where we looked at 113 patients who received either gilteritinib alone or as combination therapy for the treatment of relapsed and refractory AML. The CRC rate, again, nearly 50%, and the response rate was maintained in those patients who had been treated kind of similarly to ratify midostaurin with induction and consolidation chemotherapy at 50, that was 58%. So again, very similar to what we've seen. And it looks like with this body of data that prior TKI use, i.e. prior midostaurin, doesn't impact the response rate to the more potent FLT3 tyrosine kinase inhibitor, gilteritinib. Mutations in the RAS pathway mutation, including KRAS, NRAS, and PTP-N11, predicted lower CRC rates, and this has been corroborated in laboratory data as well. The Astellas looked at their data as well. So with Astellas, we looked at patients who had been treated on Chrysalis, which was the phase 1 study with gilteritinib, and then Admiral, which is the randomized randomized phase 3 study that led to gilteritinib's approval. And we found pretty much the same thing, that individuals who had prior tyrosine kinase inhibitor and received gilteritinib had a pretty similar response rate, whether or not they had the prior tyrosine kinase inhibitor. And I want to, unfortunately, I'm going to go. I think I can go back. Hold on. I had listed here kind of multiple mechanisms of resistance, but that isn't showing on my slide, and I apologize to you. But the mechanisms of resistance with gilteritinib include either kind of continuation of the FLT3 ITD mutation and lack of response via that mechanism versus what I've already mentioned, the RAS pathway mutations. It's very interesting that the predominance of patients especially who are treated with these, the potent FLT3 inhibitor, i.e. gilteritinib, relapsed with non-FLT3 clones. So we've seen unusual mutations that occur, including BCR-ABL, so important to think about in your patient population. But the majority of the time, we're seeing non-FLT3 dependent clones as the mechanism of relapse. So important to think about as we start thinking about next lines of therapies for patients who relapse after gilteritinib. So I have 2 conclusion slides. I know this one says conclusion. It's kind of like a lie, though. So based on the data that we've discussed already, the Admiral data stands, higher response rate, better tolerance than chemotherapy, whether or not that's the data that was presented and conducted in the randomized phase 3 study or based on real world evidence. Gilteritinib can be used as a bridge to curative allostem cell transplant, and there's improvement in overall survival when it's utilized post-allo transplant. We've continued inquiry into mechanisms of lack of response, mechanisms of resistance, combination therapies as well. And I want to end with a final case. So this guy's name is Ray. His story is public. He is one of the first patients who was treated with gilteritinib. He was in the Chrysalis study, and I'd like to share a little bit about him. So Ray was diagnosed with trisomy 8 AML with a FLT3 ITD and NPM1 mutation and leukemia cutis at the age of 66 in June 2013. His disease was refractory to 2 cycles of clofarabine, which was given on a cooperative group study in the United States, comparing clofarabine to 7+3 induction chemotherapy. He was then treated with a high-intensity chemotherapy, a MEK-based chemotherapy regimen, with a targeted novel agent, but his response was fleeting. It lasted less than a month. And then in November of 2013, he was treated with ASP2215, now known as gilteritinib, on the first in human phase 1 clinical trial. He was treated with 20 milligrams of gilteritinib. He achieved a complete remission. He underwent a double cord stem cell transplant in January 2014, and he continues to be alive and well today. So I am going to note my acknowledgements and stop there. I'm very lucky to work with an incredible group of colleagues at my institution As mentioned, I have the privilege of being very involved with the National Comprehensive Cancer Network, the National Cancer Institute, and our cooperative group, and lots of colleagues who we are able to think through a lot of these topics together and help each other and help our patients. Thank you very much.
Thank you. Thank you so much. That was an absolutely wonderful lecture. You've highlighted many important points, and there's also a lot of questions that are coming in. But before we move to the panel, we have Dr. Amrita who's joined us. And I hand over to you, Amrita, for your talk on the overview of AML treatment, Indian perspective. We're running a little late, so I request you to wrap your introductory talk in 10 minutes. Thank you, Dr. Amrita. And we request Dr. Jessica to hold on because we need you and your expertise in our panel. Thank you. Amrita,
First of all, my apologies for joining late. Some gadget trouble.
Ma'am, we are able to see you now, although the voice is a little feeble.
Okay, but can you hear me now?
Yeah, we can hear you. Now it is very clear. Yes.
Just a moment. So for some reason, I think I'm unable to join the meeting on my laptop. So I'm just using my mobile.
So,
Can you
ma'am,
hear me now?
Yeah,
we
we can
can hear
hear
you.
you. Would you like us to
Yeah.
share your presentation?
Yes, please.
Okay. Yeah, it is on screen, ma'am. Over to you.
So first of all, I would like to thank Astellas for giving me this opportunity, and I would strictly stick to the timings, 15 minutes or 10 minutes. So when we talk about AML treatment in India, can we go to the next slide, please? So all of us know that AML is a very heterogeneous disease, even though two patients have acute myeloid leukemia, the disease biology is different in every patient. The mutations and the cytogenetics and the disease biology is entirely different in two patients. We really need to look at tailor-made. And there, all of us know that there has been a paradigm shift in the management of AML. We are moving slowly away from intensive chemotherapy towards more targeted agents. If there was a druggable mutation, you would probably use a targeted agent in the management of AML. And all of us know that a bone marrow failure results from AML, and AML tends to progress rapidly. So can we just skip the slide? Next slide, please. And all of us know that AML has a very poor prognosis with a 5-year survival rate of only 20%. I think if we said 20% to most of our patients, I think people would just not want to be treated. But those are the rates of that is the 5-year survival rate of only around 20%. And the disease becomes even more difficult to treat in older patients. We see that the patient survival drops as we progress, as the age progresses. With each decade of life, the patient survival drops with a very dismal survival rate in somebody who is more than 60 or 70 years of age. Next slide. Now, the factors that affect AML prognosis, there are patient-related factors and there are disease-related factors. When it comes to patient-related factors, obviously age, even though people talk about chronological age and biological age, chronological age is important. Anybody who is greater than 60 years of age tends to have poorer disease biology. They tend to be resistant to chemotherapy and they tend to be resistant to drugs. And with age, you have comorbidities, and obviously poor performance status is also another factor that is associated with poor prognosis. If you had organ dysfunction, be it coronary artery disease or liver disease or CKD, obviously the prognosis is much worse in these patients. When it comes to disease-related factors, apart from cytogenetics and molecular abnormalities, the presence of a pre-existing myeloproliferative neoplasm or a myelodysplastic syndrome, AML that arises after treatment for another cancer, like in breast cancer survivors, the presence of the presence of an infection in the patient, be it a fungal pneumonia or let's say a perianal abscess, all these are other factors which would contribute to a poorer prognosis, because these are the patients that would tolerate intensive chemotherapy poorly, and probably these are the patients that would also be resistant to chemotherapy. And anybody who has an induction failure, obviously these are the most difficult patients to treat. Next slide. When it comes to management of newly diagnosed AML, we know there are two phases. We have an induction phase that everybody goes through, and then we have a consolidation phase. Induction phase is to uh, get rid of the blast in the bone marrow to achieve a morphological remission and as deep a response as possible. And then you consolidate the response achieved with induction with further cycles of chemotherapy. And the aim of consolidation is to decrease the chances of relapse. And consolidation could either be further chemotherapy or it could be a stem cell transplant. Next slide. Now, treating older patients and patients with comorbidities is extremely tough, as I've already said. And we know that AML is a disease of old age, though we do see younger patients. It is primarily a disease of old age. And there was a time where we did not have venetoclax on our radar. We used to treat patients with single agent azacitidine or single agent decitabine with extremely poor complete response rates. The duration to response was also longer with single agent azacitidine and decitabine. Venetoclax has kind of changed the way we treat older patients and patients with comorbidities. And obviously, apart from hypomethylating agents and hypomethylating agents with venetoclax, best supportive care is also offered to a very few unfit elderly patients in whom we think it's not even worth giving them hypomethylating agent with venetoclax. But obviously, the number of patients who we offer best supportive care has drastically reduced in the era of hypomethylating agents with venetoclax. Next slide. Now, when it comes to relapsed refractory AML, obviously, relapsed refractory AML, the only thing that can cure these patients is a stem cell transplant. And the aim of treating relapsed refractory AML should be to get these patients into a remission as quickly as possible and as safely as possible without them picking up an infection or without compromising their performance status, so that ultimately they could get to a transplant, which is what is going to really cure the patient. Now, when it comes to relapsed refractory AML, some of the few points that we would consider when we talk about treatment is the duration of the first remission. If it was less than 12 months or whether it was more than 12 months. If it was more than 12 months and if the patient is fit, it is worthwhile challenging the patient with the previous chemotherapy regimen that was used. But if it was an early relapse less than 12 months, obviously we need to try something different. And different could be more intensive chemotherapy, a more intensive chemotherapy protocol. If the patient has received 3+7 initially, maybe a flag IDA or a ham could be the way to go. But then we have venetoclax that is available to us in India right now. So I would, I'm speaking entirely, it's an entirely personal point of view. I would rather give a less intensive therapy, do azacitidine, venetoclax in a relapsed refractory AML patient, get him or her into a remission, and then offer a stem cell transplant, which is what is ultimately going to cure the patient. The presence of a FLT3 mutation would obviously change things, which we will discuss in the coming slides. Next slide. Now, chemotherapy we know is used in the treatment of AML. So if it was a young and a fit patient in India, we would be giving a 3+7 induction. And high-dose intensive chemotherapy is what we use in younger and healthier patients. In patients who are unable to tolerate high-dose chemotherapy, we use a hypomethylating agent with venetoclax. Next slide. Let's skip all this. Now, if we talk about unmet needs in AML, I think younger patients who are refractory to conventional chemotherapy and older patients with comorbidities are two subgroups of patients who are particularly difficult to treat. It's difficult to treat a young, let's say 40-year-old patient who has a TP53 mutation. You have already given a 3+7 and he's failed one induction, and then giving him further therapy in a young and fit patient who has refractory AML, trying to get him to a transplant. This is a difficult subgroup to treat. Apart from that, we have the elderly patients who are again difficult to treat because their performance status is not really great. They have comorbidities and they have disease that is resistant to chemotherapy. Next slide. Now, this is just to show you that worse the performance status, and as the age increases, the 30-day mortality rate from initiation of induction chemotherapy increases. Next slide. Now, talking about targeted therapies, we'll just focus a little bit on FLT3 mutations. Next slide. I think Dr. Jessica has already covered all this. We know that the FLT3, the FMS-like tyrosine kinase, is a receptor kinase, and it is constitutively activated in AML cells and provides them with a survival advantage. And it is seen in 1/3 of patients with AML. It has been detected in around 37% of patients with AML. And FLT3 gene mutations, they cause proliferation and block differentiation in leukemia cells. Next slide. Now, this is just a diagram of the receptor, how it looks. We know that the internal tandem ITD mutations happen in the juxtamembrane domain. And apart from that, we also have the TKD mutations. ITD mutations, irrespective of the allele burden or the allele ratio, they confer a negative prognostic value. And I think most centers around the world would offer a transplant in first CR for most of these patients. Apart from that, the TKD mutations, though they are present, their role in prognosis is not very clear as compared to the ITD mutations. Next slide. Now, if we talk about the current treatment approach in FLT3 positive AML, even in India, we would do, if it was a young and a fit patient with newly diagnosed FLT3 positive AML, we have midostaurin that has been available to us for many years right now. We would do a PCR, we would do a FLT3 testing by PCR, and most labs give PCR results within 7 days so that we are able to start midostaurin on time. Induction would consist of a 3+7 cytarabine with daunorubicin with addition of midostaurin from day 8 to 21. And if the patient achieved a CR, preferably these patients should go on to receive a bone marrow transplant if they had a suitable donor. If a suitable donor was not available, then you would probably consider high-dose consolidation with cytarabine, high-dose cytarabine with midostaurin. If somebody was refractory to initial induction, you would consider salvage chemotherapy. If we talk about India, if there was a refractory salvage, if there was a refractory FLT3 positive AML patient, I think most of my colleagues in India would offer them either gilteritinib or maybe do azacitidine venetoclax because we have access to both drugs in our country right now. Is it worthwhile? One point which I really wanted to address is there are multiple case series which kind of tell us that FLT3 mutation testing should happen not only at the time of diagnosis, it should also happen at the time of relapse because the mutation status can change. Sometimes the FLT3, somebody who was FLT3 positive could end up being negative at relapse. And somebody who was initially negative could acquire a new FLT3 positive clone at relapse. So it is important to do testing for FLT3 mutational status, not only at the time of initial diagnosis, but also when you consider any salvage therapy, before considering any salvage therapy at the time of relapse. Next slide. Now, this is just a slide talking about targeted therapy in AML. As I've said, we are slowly, there was nothing for many years, many decades apart from 3+7. Now we are moving towards more targeted therapies, venetoclax, gilteritinib, and hopefully we should have more targeted therapies available in India to us soon. But then venetoclax and gilteritinib has kind of changed the way we manage relapsed refractory FLT3 positive AML and AML in the elderly. Next slide. So this, I think Dr. Jessica has already covered about type 1 FLT3 inhibitors and type 2 FLT3 inhibitors. Type 1 FLT3 inhibitors, they bind in the active conformation, and type 2 inhibitors, they bind in the inactive conformation. Type 1 are active against both TKD and ITD, and type 2 only against ITD. Gilteritinib and midostaurin are both type 1 inhibitors. Sorafenib is a type 2 inhibitor. These are the only drugs that we have available in India. Next slide. Now, testing for FLT3 mutations, we want the turnaround time to be short as early as possible so that we can intervene at the time of induction therapy. So most labs, they give us a PCR report within 5 to 7 days. And PCR is what I think most of our colleagues do. So FLT3 mutation testing by PCR is what is recommended. It is highly specific and it only detects mutations within the amplified region. Next slide. Can we skip the slide? Next slide, please. Now, the impact of FLT3 status on outcomes in first relapse, we know that if somebody had a FLT3 positive, if somebody was FLT3 positive, they did not do well. Patients who had AML and FLT3 mutation at diagnosis, they have shorter overall survival from the time of first relapse compared to those who have FLT3 wild type. Next slide. Now, patients, again, this slide just goes on to show us the fact that patients with AML and FLT3 mutation at diagnosis, even if they achieve a second remission, they still have a shorter overall survival as well as a shorter duration of second CR compared to somebody who had a FLT3 wild type. Next slide. Now, the presence of a FLT3 mutation in relapsed refractory AML, it is an independent marker of an adverse prognosis. Even though the p-values are not very significant, the event-free survival and the overall survival at 2 years were numerically lower in the FLT3 positive group compared to the FLT3 wild type. Next slide. So just again, I would like to stress this point. So these are multiple studies in which they have looked at, different numbers of patients. And this slide just goes on to show the fact that there are people that the FLT3 status can change during the course of AML treatment. And it is worthwhile checking again for FLT3 mutational status at the time of relapse. Next slide. The allelic ratio is kind of not given too much importance these days. We do not look at the allelic ratio. We just look at whether somebody has a FLT3 mutation or not. But having said that, somebody with a higher allelic ratio does poorly compared to somebody who had a lower allelic ratio. Next slide. This is again how the FLT3 mutation status can change after the use of FLT3 inhibitors. So if you used a FLT3 inhibitor, again, your FLT3 mutation status can change. Next slide. So this is again, so I would just like to summarize. Let's just go to the last slide, please. So mutations within the FLT3 gene, they are one of the most frequent genetic alterations in AML, seen in about a third of patients. And mutations in FLT3, irrespective of the presence of NPM1 or not, they confer an adverse prognosis. And most centers around the world would kind of consider these patients for a transplant in first CR if they had a suitable donor. And multiple case series have shown that the FLT3 mutational status can change with treatment and may be different at the time of relapse. If somebody was initially negative, they could acquire a clone later on. So it is important, especially when we have access to gilteritinib, to check for FLT3 mutation status even at the time of relapse and just not presume that somebody was negative at the time of diagnosis. So let's not test it again. So, and change in FLT3 status can impact patient survival. Somebody who continues to stay positive, they do not do well. And somebody who was initially negative and later on became positive for a FLT3 mutation are the patients who actually have the worst prognosis. And FLT3 testing should be carried out for patients at relapse. With this, I'll end, and I would again like to thank Astellas for this opportunity.
Thank you, Dr. Amrita. You've highlighted a lot of very important points. I appreciate your talk. I now hand over to Dr. Sarita Jaiswal, who will be conducting a panel discussion on the key considerations in the transplant journey for fit patients with relapse and refractory AML. So over to you, Dr. Sarita. And in this panel, we'll be having Dr. Jessica, Dr. Amrita, Dr. Tejaswini Vaid, and myself. Thank you.
Good evening, everyone. I hope my slides are visible and I'm also audible.
Yes, ma'am. Yeah.
So I thank once again for inviting me and just asking this important discussion with the eminent people like Dr. Jessica, Dr. Tulika Seth, who is a renowned Indian in the setting of women platform, Dr. Amrita, Dr. Tejaswini. So the topic for today's discussion is our key consideration in transplant journey for fit patients with relapsed refractory AML. So we know that after the discovery of this next generation sequencing, we can find the mutation analysis, we can find, and so this has evolutionized the treatment of acute myeloid leukemia. And what we found out that yes, there are a few mutations which are very common, like FLT3 ITD mutations. Approximately 30% of population who is developing AML, they might have, it has already been discussed. So I'm not going to detail IDH1, NP1, NPM1, TP53, and the RAS pathway mutation. These are the common mutation we find nowadays in AML. Now, coming to the case, like a 36-year-old male patient who presented with the low-grade fever for 2 weeks, and he was also complaining of gingival swelling and pain while brushing teeth and epistaxis on and off. On evaluation, what we found that the WBC count was 44 into 10 to the power 9 per liter, and the platelet was on the lower side. So we did the bone marrow, and bone marrow revealed 72% of the blast with a monocytic phenotype. And after the genomic analysis, NPM1 mutation, along with FLT3 the mutation, ITD mutation, which came in. And apart from these two, the DNMT was also found out. So we started treatment with induction, standards induction 7+3, 60 milligram of daunorubicin on day 1 to 3, cytarabine. And at that time, 50 milligram of midostaurin was started. And so patient achieved a bit of response. Then again, consolidation was started with HiDAC, 3 gram per cytarabine, 3 gram per meter square. So on day 1, 3, 5, these were given, and along with, so my then what happened? But unfortunately, after this first consolidation, patient developed neutropenic sepsis, and gradually it was seen that his blast count, blasts are coming up, and finally peripheral blood leukocytosis was found out, and 48% of the blast. So obviously we know that this patient has relapsed. So my first question goes to Dr. Tejaswini or Amrita, whoever is available. What would be the test that you would prefer to do before deciding on subsequent therapy? Do you want to do repeat bone marrow, or do you want to do FLT3 testing again? So what's your standard protocol? That's so over to you, Dr. Amrita or Tejas. Hello.
Thank you, Dr. Sarita. At our institution, if the patient has achieved a remission at any point and then relapses, we always conduct a repeat bone marrow biopsy. It allows us to take a good sample for the karyotype. It allows us to rule out a rare mixed phenotypic acute leukemia. So we make sure that if it's a relapse, we do a repeat bone marrow. And would I go for a FLT3 testing again? Yes. We would repeat a FLT3 testing in our patients if the patient has relapsed, irrespective of the baseline, whether the FLT3 was positive or not, because most patients who relapse do have a FLT3 clone, and but there will be an occasional patient who will relapse without the FLT3 clone as well, and that would be important from therapy perspective.
Yeah. Amrita, do you have something different opinion? Is Amrita there?
Yeah, I'm here. I'm not very sure about this particular patient. I would love to hear Dr. Jessica's thoughts, because this patient was hardly in a remission. Maybe just for a month or two, she had a very short-lived remission. So if it was, like, say, somebody was in remission for 6 months or 5 months or anything less than a year, I would I mean, this is a very short remission period, so I am not sure whether I would definitely not repeat the marrow, because I don't think the cytogenetics would have changed within 2 months. I would not do a marrow. We already have blasts on peripheral smear, so we know it's a relapse. And I'm not very sure in this particular patient whether it would be worthwhile doing a FLT3 testing, because the remission duration was extremely short, maybe 1 or 2 months maximum, or just presume whether the patient was is FLT3 positive still, and probably just give gilteritinib in the coming therapy. So I would love to hear Dr. Jessica's thoughts about this particular patient, especially when the remission duration is just 1 month or 2 months.
Dr. Jessica.
I'm not sure about this particular patient.
Yeah.
Sure, I'd be happy to comment, Dr. Amrita.
Yeah. Go ahead.
And Dr. Vaid, you both made beautiful points. I am lucky that I live and work at an institution where I have lots of resources. And so we don't really think about cost containment a lot of the time. There's a lot of time we do, but this is absolutely a patient that I would consider not repeating a bone marrow biopsy, because I think it's unlikely to show anything new. It is a patient that, despite that, at my institution probably would have a repeat bone marrow biopsy, because we would probably be thinking about a clinical trial, and it's just kind of an institutional norm, just like Dr. Vaid mentioned. But this is still someone that I would repeat FLT3 testing, because I want to make sure that the FLT3 mutation is present. I agree with you 100%, Dr. Amrita, that the FLT3 mutation is almost uniformly still present, but we would do FLT3 testing. We would do a whole NGS panel to see if there are other new mutations that have developed.
Yeah, definitely. Biopsy is not indicated, but yes, flow cytometry we can do. We can see the population. And I would love to do, because genomic thing, that whether you have to see whether something extra has come up or not. That's the only reason. So going ahead, this slide is not moving. Is the slide moving?
Can the organizers help? You're projecting, or
Hello,
I
ma'am,
am.
can you try moving once again?
try it again?
It's not moving.
मैम एक बार स्क्रीन पे क्लिक करके फिर ट्राई टू मूव द स्लाइड्स
Click on the screen and then
क्लिक ऑन द स्क्रीन या
So I think I have to reload it, reshare it. I'm just
from share and
Khushi, can you share it from your end, please?
yes.
Yeah, sure, ma'am.
So while we're setting up the slides, there is a few questions in the chat box. So one of the questions is from Dr. Madhu Parna, and she says that the trial mentions that guilt has good response in FLT3 along with other co-mutations like DNMT3 and AXL1. And she's asking, does this reflect in actual practice? So Dr. Jessica, would you like to answer that question?
Sure, I'd be happy to. Thanks for asking the question. I think for folks with a DNMT3A mutation, the response is maintained. The data supports the ASXL1 mutation with response being maintained as well. I think certainly clinical practice may be a little bit different than that. The patient population where I have seen less of a response are those individuals with the RAS pathway mutations, especially if they've had a prior FLT3 inhibitor like midostaurin, or patients who have a TP53 mutation, meaning kind of that the FLT3 clone is not kind of driving the disease, that it might just be a subclone. So those are the patient populations where I see not as much response, but those are still individuals where we kind of give them the benefit of the doubt and offer gilteritinib.
Thank you. Back to you, Dr. Sarita.
Proceeding to that, so we repeat the molecular testing, and this recurrence of NPM1 DNMT-R 888, 882, and FLT3 ITD. So as per this NCC guideline, we know that this CBC after this bone marrow is only indicated if peripheral smear is abnormal or cytopenia develop. And at the same time, for the treatment part, we have to look for the donor search. And if really patient has relapsed, so if there is no donor available in the family or in the registry, then yes, go ahead with the other targeted therapy followed by salvage chemotherapy, and repeat initial successful induction regimen if more than 12 months since induction regimen, or other best supportive care, whatever is available. So this was the NCCN guidelines. So my question to you, Dr. Jessica, or Dr. Tulika, what do you do because you are dealing with in a big center, and what method do you use to find the FLT3 testing, PCR or NGS?
So at AIMS, New Delhi, we have a PCR that we do for FLT3, but we do the PCR only at diagnosis. Our PCR is not set up for monitoring later on. For later on monitoring, we actually have we have to go to an external lab. There are one or two very good external labs that have been set up that do NGS. For the PCR, our turnaround time for the in-house PCR is 1 week. The NGS, which is being done by Astellas and a few other very good labs, the turnaround time is about 4 days. But we don't have the NGS in-house.
Yeah, we are thankful to these Agilis company that yes, turnaround time has been decreased. So Dr. Jessica, any thought about?
We have a similar practice. I'm happy to comment. So we do FLT3 ITD testing in-house, and we do NGS testing that includes most of the FLT3 ITDs, but some of the very long FLT3 ITDs are not always picked up by NGS testing. And that's true both in some of our national labs and at many institutions. So it's important to do PCR testing if accessible. For monitoring, we have in-house, we have a digital droplet PCR testing that gets down to pretty low levels. We also, in necessary patients who are like, we're thinking about stem cell transplant decision making, we also send out, we use in vivo scribe, which it sounds like is similar to the testing that you guys just mentioned.
So do you change the allelic ratio as well?
We do get allelic ratio in addition to the variant allele frequency. From a clinical perspective, I tend to just use a variant allele frequency. It's a little easier for my brain, but we also get an allelic ratio.
Yeah, thanks. So, so what about this in terms of efficacy? What endpoint do you consider most meaningful to your practice, Dr. Jessica?
Sure. So I kind of depends on the patient in terms of the endpoint and the patient's goals. So for someone who is not going to stem cell transplant, I think clearly an overall survival and quality of life considerations are paramount. For patients who are younger with a goal of stem cell transplant, my goal is the CR. And if I'm making a decision in the future about whether or not I'm going to be transplanting FLT3 ITD mutated patients, then MRD testing. So today at our institution, we are still recommending stem cell transplant for FLT3 ITD mutated patients, even with an NPM1 mutation, though based on the Othman and other data, that might change in the future as we have more experience. So I'll kind of re-summarize because I'm talking in circles. For the transplant patient, my primary goal always for every patient is overall survival, but for my immediate decision making is CR with MRD status.
Okay, thank you. Dr. Tejaswini, any thought?
I second that. As Dr. Altman pointed out, that although the Admiral trial has shown that gilteritinib clearly has benefit in terms of improving the CR and the overall survival rates, but these remissions are not very long lasting. So the best utilization for young fit patients is to use these remissions to put them to transplant. And where a transplant can't be provided or is not an option because of poor fitness, for them, overall survival, transfusion independence, and quality of life are better focuses for us.
Yeah, thank you. So,
Dr. Sarita, there's a question on gilteritinib for patients going to transplant. So maybe Dr. Jessica can say, so patients who are going to transplant and are on gilteritinib, do we need to make any changes? Do we have to stop the medicine, or do we just take the patients up for transplant? That's a question by...
Sure.
Yeah. Go ahead.
So that's a great question. We've tended to stop it the day before they come in for conditioning therapy and keep folks on it. It also depends on, right, if they're on it for relapsed disease and are in a remission, I want to hold on to the medication for as long as possible. If it's a newly diagnosed patient, if it needs to be stopped a couple of days or a week before, I have more comfort for that. If the patient's in a deep remission, that's a conversation we have with our transplant physicians. I think, Dr. Toluca, that there was a question about gilteritinib post-transplant and considerations as well. I can address that right now also. I think the question was stemming what concerns there are. And so while we haven't talked about it, I draw that my data for that from the Morpho study. And the biggest risk, I think that was the question, what are the biggest risks? It looks like the GVH is pretty similar in those who receive placebo versus gilteritinib. However, there does appear to be a higher infection risk and some myelosuppression with gilteritinib. So it's important to note. And I think that study and the subgroup analyses looking at the differences across regions is really fascinating and something that I'm hoping as the community will continue to be able to study.
so if you have to stop it, so how many days before you stop, before starting the conditioning?
So at our institution, we generally stop 1 to 2 days, especially if they have relapsed disease. But I'm interested in what all of you do.
Okay.
I think
So-
it's fairly new for us. We've just started
Yeah.
2 patients who on gilteritinib, so we don't really have too much data. We're hoping that they're going to do well and we'll be able to take them to transplant.
Great.
There are a few cases only with us also, so we cannot comment on that. Those depending on those 2-3 cases. So obviously, in due course, when we will have the more and more number of patients, we will be able to comment on that. But yes, before 7 days before starting the conditioning, we stop it. So moving on to next question, so how many patients respond to the treatment with these therapy FLT3? So 10 to 20% patient, 25 to 50% patient, and more than 50% of the patient. Dr. Jessica, can you comment on that?
Sure, I'm happy to. So I think the real world evidence that I shared with you for relapsed and refractory disease, anywhere between about 30, 40, 50% of patients, depending on what you're looking at and how you're defining your response. But that's kind of the number that I keep in mind. And also, when you look across, then you start to utilize some of the other targeted therapies, IDH1, menin inhibitors. I kind of keep that number of about 30 to 40% in mind in terms of what we can counsel our patients for response. So all the targeted therapies as single agent are somewhere in that space.
Definitely. And what challenges do you face with the gilteritinib?
So yeah, so I think it's a really well-tolerated drug. I do the monitoring that I discussed. I monitor EKGs, we monitor labs closely. We see asymptomatic rises in CK, which don't bother me or my patients very much. And I follow for myelosuppression. The differentiation syndrome is different than the differentiation syndrome we see with ATRA and arsenic or the menin inhibitors or the IDH inhibitors. It's kind of idiosyncratic. It can happen early, it can happen late. It can present kind of only with skin changes. There's a lot of the differentiation effects of gilteritinib are unusual and worth kind of thinking through.
So Dr. Amrita, your comment, please.
So I haven't used gilteritinib in that many patients. We know that it is seen only in 1/3. The FLT3 mutation is seen in only 1/3 of AML, and the number and we use it only in relapsed refractory AML. So I have just one patient in whom I'd used gilteritinib, if I have to be really honest. She was an elderly FLT3 positive AML who I had given azacitidine venetoclax as first line treatment, and then she relapsed 6 months later. And then that was when I gave her gilteritinib. But then her performance status was very poor. She was 80, if I remember right. She did not do well. She did not make it through the entire month. And that's the only personal experience that I have of this drug.
Thank you.
I have a question for Dr. Jessica. So if in somebody who has a relapsed FLT3 positive AML, if they presented with hyperleukocytosis, let's say they had a TLC count of more than 1 lakh at the time of relapse, would you just start them on gilteritinib, or you would combine it with some chemotherapy, or what would be your drug of choice in a relapsed refractory FLT3 positive AML who presents with hyperleukocytosis?
Great, thanks. So good question, because we don't know the answer to that. And this is style and kind of depends on whether or not the patient's having symptoms related to their elevated white blood cell count, or if they're just kind of asymptomatic. I tend to, in the patients that I presented, you may have noticed that they all got hydroxyurea. Generally, FLT3 mutated disease is responsive to hydroxyurea in our hands. If not, I don't have concerns. In fact, we utilize it when necessary. A little bit of cytarabine, either kind of flat dosing of 500 milligrams, half a gram or higher, depending on the patient's functional status, age, organ function, and what's going on clinically. But I do try to get the white blood cell count down, because gilteritinib can take a little bit of time, but gilteritinib does work well itself to bring down the white count. I just get a little anxious. And like many of you, while I may know the FLT3 mutation from before, it might take a couple of days at my institution to get the FLT3 results. So I wait to start, and it takes time to get the results, and it can take time to get insurance authorization for the medication. So I utilize those supportive regimens to get the white blood cell count down.
So
Thank you.
this is a fascinating discussion, and I'm told by the organizers that we need to wrap up this panel. So I would like to give my utmost thanks to Dr. Sarita and Dr. Jessica, Dr. Tejaswini, and Dr. Amrita for this fascinating panel. And even though I'm loath to let go of it, but I must introduce the next moderator. And we are delighted to have Dr. Manisha Jain, and she's going to be conducting a panel discussion on navigating treatment options for transplant unfit patients with relapse and refractory AML. So over to you, Dr. Manisha, and your panel. Would you like to introduce your panel?
Either way, ma'am, you can also introduce. That would be very great.
Okay, so wonderful. So your panel, again, we have Dr. Jessica with us. We have Dr. Priyanshi and Dr. Padmaja and Dr. Nivedita Dhingra, all of whom I'd introduced at the beginning. So over to you. Thank you.
Thank you so much, ma'am. Good evening, everyone. I'm Dr. Manisha, and it was really, I'm highly obliged to be part of this. We have already discussed so many things. Nothing new has been left out, and it is a great discussion going on. And would be happy to share some more data on the transplant ineligible patients, because in transplant eligible, we even have some option of giving HSCT as a consolidation therapy for the patient. But the patient who are not fit for HSCT or other way can't afford HSCT, if we can provide some targeted therapy to the patient with minimal side effects and good efficacy, that would be great. So can I request organizers to please share my screen?
Ma'am, it is
So,
coming up. Yes.
yeah. Thank you so much. So this is just the disclaimer. Next slide, please. So just a few of the cases, very interesting. There are 3 cases. Every case is unique. I'm just trying to finish off very quickly so that we can discuss some important points over this. So this is 68 years old AML with FLT-TKT mutations who presented and received the intensive chemotherapy. Post-induction bone marrow was in CR, and that followed by the consolidation therapy. And also CNS prophylaxis was given to the patient. Relapse was observed after 5 months. The important point of this is the comorbidities with the patient. The patient has end-stage renal disease, there was hypertension, type 2 diabetes mellitus, and dyslipidemia. And with this picture, comorbidities, the patient presented after 5 months with relapse AML with FLT3 TKT mutation. It was reinsertion chemotherapy was given, and bone marrow biopsy consisted with MR at day 35. Consolidation was given with decitabine and midostaurin for 12 cycles. Next slide, please. So patient relapse. After this, as the patient presented with pancytopenia, we have to do the bone marrow, which shows 80% blast, and overall clinical conditions because of multiple comorbidities was very bad. So patients accept their condition and plan to go back to palliative treatment, but after bringing down the disease burden. Next slide, please. So we already have discussed it. The patient has multiple comorbidities. The patient general condition is not that fit for multiple intensive chemotherapy. So this is an open thing for everyone, whoever wants to give. And definitely, Dr. Jessica, please give your inputs, because it will give us the insight of FLT3 inhibitors. So how would you proceed ahead with the treatment for these patients having so much comorbidities, including the renal failure requiring dialysis?
Great. So thank you. So this is a patient with renal insufficiency on dialysis with relapsed FLT3 mutated disease, correct? So this is a patient that I, if they have the FLT3 mutation, would continue to offer gilteritinib. There is not data that I'm aware of for the utilization in folks with renal insufficiency, but it is my understanding, and I'm hoping that someone can corroborate this on the call. It's my understanding that most of it is metabolized through the liver, so I think it would be acceptable. And what even drugs that aren't metabolized that way, that I just monitor for toxicity and adjust accordingly. But I still offer
Would
them
you
the
use the
medication.
same dose? Would you use the same dose in these patients, or
Of
would you like to
120.
start with a lower dose? And
So I would probably start at 120 milligrams and monitor closely for toxicity, but I'm also really fortunate that I work with pharmacists both in the hospital and outside the hospital who would probably, in this instance, reach out to Astellas, ask what experience exists, and then we would talk through it based on the metabolism of the drug. And so, yes, it's possible that we would start with 80 because 80 still inhibits the PIA. Yeah.
so can I request any of my panelists, Dr. Priyanshi, Dr. Padmaja, to comment over this? How would you proceed in this kind of patients in Indian?
Absolutely. I think it's a tough one. Lots of comorbidities. You can't do a lot. This patient has failed relapse very early on with an aggressive disease. You are going to retest for FLT3. More likely, this is going to be tested again positive. It's good that it's TTD, not ITD. But at this current scenario, we've got gilteritinib, so I would be going ahead with that. A couple of months back, when we didn't have a single agent gilteritinib, you're probably looking at aza-ven and adding in continuing midostaurin and all these kind of things. As you've just used decitabine, you can use another epigenetic molecule. But at this current time, if the same patient comes, I would use a single agent gilteritinib, maybe start with 80 and then escalate it if she tolerates. And perhaps the close monitoring of blood tests as she's pancytopenic to support, check the liver, ECGs for all this, QT prolongations and take things from there.
So I will also consider with azacitidine, probably gilteritinib as well, but the dose I will keep little lower, maybe 40 mg with posaconazole, so that the level of the drug increases. And if there is no grade 3, grade 4 cytopenias, I will probably in coming few days, like maybe in week later or so, will increase the dose to 80 along with the any azoles. So like that, I will proceed with this patient.
Great. Although I was planning to discuss this interaction between azoles and the gilteritinib later on, but as it is pointed out, I would too like to have some idea how, Dr. Jessica, you are using antifungal prophylaxis in this patient because they are neutropenic and most of them after relapse, I think in Indian scenario, they had one or other episodes of fungal pneumonia. So we have to use prophylaxis as primary or secondary for these patients. So how do you fit gilteritinib with azoles?
Great. So thank you. So we have not adjusted the dosing of gilteritinib with azoles in our patients in relapse disease. We monitor closely. We monitor the QTC prolongation. We monitor for cytopenias. I recognize that in the studies that there was concern, but we utilize azoles pretty regularly at our institution and most of my colleagues throughout the US. So I recognize that that's an issue, and I'm okay with you starting, at a lower dose and monitoring, make sure the folks tolerate it, and then increasing, or if you get the response you need, continuing 80 milligrams. But we have generally used 120. The times that we do dose adjust are times when we use in combination therapy. I know someone in the chat had a question about combinations. So if there are further questions, I can address that.
Right. So we already have discussed that every time the patient relapses, we do the FLT3 testing as per the institution policy. Next slide, please. So similarly, this is the guidelines that NCCN says that we have to do the FLT3 testing at every relapse. Next, please. Next slide, please. So before gilteritinib was introduced, this relapse refractory setting, FLT3 TKD was still a problem for all of us. So what was your choice of treatment for this kind of patients? Dr. Jessica, please. Before gilteritinib.
Before gilteritinib, so for folks who are not fit for intensive chemotherapy, these are individuals based on the VALIA data that have a really nice response to azacitidine and venetoclax. And so this is a patient that I would consider that for. As if your patient is with significant renal insufficiency, we clearly worry about tumor lysis syndrome and the worsening renal insufficiency when we start a venetoclax-containing regimen. That being said, we've utilized this in individuals on dialysis or impending dialysis in consultation with our kidney doctors.
So any comment from our panelists, Dr. Priyanshi, Dr. Padmaja? I think Dr. Nivedita has not joined. Is she there?
No, ma'am. Dr. Nivedita could not join due to some family emergency. Maybe
No issues.
other doctors can
So,
definitely pitch in.
right, sure.
So,
Dr. Padmaja, can I request you? Yeah. Sure, Dr. Priya,
yes.
please.
So basically, I would like to give this patient azacitidine and venetoclax, and they have written the question before gilteritinib, so might add midostaurin as well, all the three drugs, and will monitor the patient gradually. Will try to continue the regime as much as possible, so much so that the patient achieve remission. So I would like to add azacitidine, venetoclax, as well as midostaurin.
Okay. Any different thoughts, Dr. Padmaja?
No, I agree with the panelists, all the three agents, and how the treatment duration until the patient progresses. As long as the patient is in remission, we continue the treatment because this is a palliative setting. We're not going for transplant. So, yeah.
Good. So, what usually duration you give, you feel in your personal real life scenario, how many months normally patient tolerate or remain in remission with this kind of treatment before gilteritinib?
So if this patient is quite a high risk, I doubt whether they would have just with aza couple of months, whether they would attain a remission or not, whether it'll take 2 to 3 months, especially in a relapse setting with an early relapse. But with the addition of FLT3, most of the patients on a non-intensive arm who was relapse settings, you would have maximum about a year most of the times. And I tend to continue the treatment until the patient has got initially at least about 4 cycles to see whether they're going to respond or not. If they're not responded, I would stop. If they've responded and attained a complete, serological in the sense blood counts have become normal, I'll continue the treatment until the disease relapses.
Okay, fine, great. So, can I have the other slide? So yes, we have seen in Admiral study that gilteritinib has been given good benefit to these patients. Next slide, please. So I'm not to detail about the baseline Admiral trial because it's already been, we all knows. I want to discuss more about the case. So can I have the other slide? So what has been the response like in patients who present with FLT3 TKD at relapse before gilteritinib? This is just a rough idea that how the gilteritinib has changed our treatment practice in day-to-day life. Dr. Jessica, please.
Sure. So I think if you're talking about in general, FLT3 TKD patients, whether fit, unfit, young, old, I think a lot of it really depends on their co-mutations. As was mentioned by one of my colleagues earlier today, the FLT3 tyrosine kinase domain mutation has been considered prognostically irrelevant. It has been a concern when it occurs after exposure to some of the earlier FLT3 inhibitors as a mechanism of relapse. And also now with the utilization of more potent FLT3 inhibitors, we have the ability to target that in addition to the ITD mutation. So I really kind of defer, if it's just a TKD, I think about the rest of the clinical situation. But these are patients who sometimes have had very long durations of remission. And so if they're young, I would retreat them, young and fit with good organ function, I would retreat them with chemotherapy. If they're older individuals, or it's not with multiple comorbidities, or it's not in keeping with their wishes, I would give them something like an HMA ven, and sometimes add midostaurin, as my colleagues have mentioned.
Great. Can I have the next slide, please? So, so we have done the bone marrow biopsy. It's proven that AML relapsed with this. We started with gilteritinib 120 mg, initiated as the report came positive for FLT3, but we have to hold the treatment because of pancytopenia. Patient presented to emergency because of febrile neutropenia. Next slide, please. So I would like to ask my panelists, what are the side effects you usually encounter among your patients in relapsed refractory settings who are on palliative therapy, including gilteritinib? So may I ask first Dr. Padmaja?
Yeah, thank you. So this patient, if patient is pancytopenic, that is the biggest thing until they respond. You're looking at usually about 2 cycles, and you have to continue to support them with the products and push the therapy rather than giving up to see the response to it, especially if you're using a single agent, the gilteritinib. So that is one of the biggest things. Of course, the LFTs, you're on antifungals with severe neutropenia. You don't know, it could just be the disease initially. So we have to continue the therapy, like how we're doing with azacitidine and venetoclax. Despite the neutropenia, you're continuing venetoclax. So similar way, gilteritinib has to be continued at least in the first 1 to 2 cycles if the cytopenia was due to the disease. That is the biggest challenge. And later, the liver functions with azoles. A lot of Indian patients, while they're on azoles, their liver function is abnormal. So that's something, whether you could change over to enidulafungin, which is liver safe, that's something we encounter quite practically in many patients. So yeah.
Dr. Priyanshi, any other difference you want to share?
Yes, actually, I have experience with 2 patients. So, in Indian setting, we're already using azacitidine venetoclax with an immunosuppressive. And with gilteritinib, I have noticed that one of my patients developed gastritis, black colored
Oh,
stool. Okay. So once I stopped the drug, it improved. I don't, the patient were not having transaminitis or cytopenias. The other complications which I had was pneumonia, fungal pneumonia, which can be seen in other immunosuppressive drugs like venetoclax. And the third one, which is very unique nowadays I'm facing with that patient, is recurrent UTI, urinary tract infection. Okay, so my patient is developing Klebsiella pneumonia, which was sensitive to first to amoxiclav. Then I treated that. Then again she developed thereafter in a month. So we started treating with one more sensitive drug. Now third time she has developed again UTI. Okay, so this type of refractory infections I'm dealing with. So these 3 infections I'm dealing with one of my patients who is being treated with gilteritinib. So what I think that Indian patients might be having a different set of side effects than transaminitis and cytopenias, and there might be other things which we might see in our Indian patients as we go on with treatment with this particular drug.
Even Tulika ma'ams, Dr. Amrita, Dr. Tejaswini, and my panelists, do you think gilteritinib is safer as compared to other alternatives available as per Indian scenario patients who are relapsed after maybe multiple lines of therapy? Tulika ma'am?
In our experience, it seems to have very little side effects because obviously when you have a relapse patient, usually our first strategy is to give, more chemotherapy, and usually in the relapse setting, patients don't tolerate. So I think as a relapse regimen, it is one of the safer regimens that we have.
What I
Right.
believe that we constitutively we are different. So we are not, our patient do not tolerate 120 milligram, what we have seen. So what we have to do, especially in the post-transplantation period, if we really want to start, we start with the 40 milligram. And gradually, if there is no side effect, you have to increase that. So,
You're talking in the transplant setting.
yeah.
Yeah, because otherwise, we should give 120 or minimum we should give is 80. We should not give less than 80 in transplant.
Agree. And especially patients, if you are giving an MRD positive kind of a refractory disease, uh, they tolerate very well as the counts are good,
Yeah,
and
tolerate.
very well. Single agent gilteritinib in that setting is very well tolerable to get the MRD negativity pending the bridging to transplant and things. Yeah.
So I agree. Yes, post-transplant when it is maintenance, the might be the dose, lesser dose would be effective to keep it under control. But when the patient is having the disease active, MRD positive or relapse setting, I think we should not compromise the dose unless the patient is not getting tolerated or having serious side effects, which makes the treatment like difficult for the patient. Any other comment, Dr. Jessica?
My
You want to
question to
come?
Dr. Jessica is, if the patient has, apart from FLT3, if they have the other mutation, so do you include other agent as well in induction? I'm just talking about induction, not. Hello?
Okay, I'm here. I think that there were two comments. The first, Dr. Jane, I agree with the comments that everyone has made regarding the dosing. Certainly, I defer to you in terms of, evaluation management of toxicities. I think getting some real world experience from your patients in India would be a huge bonus to the world. There are Indian who are living outside of India, who are living in the UK, the United States, Canada, all over the world. We would benefit from learning about your experience. Number one. Number two, I think the question was, do I give anything else in induction therapy if I'm giving someone who has a FLT3 mutation? If they're getting intensive induction chemotherapy? No, I treat those individuals with 7+3 and a FLT3 inhibitor.
So do you ever combine the gilteritinib with venetoclax?
I do. So we have been very interested in combining gilteritinib with an azacitidine venetoclax backbone for adults who are inappropriate for intensive induction chemotherapy with newly diagnosed disease. There are a couple of studies that are ongoing in North America. The first is a company-sponsored study called Viceroy that has looked at dose optimization of venetoclax in combination with azacitidine and gilteritinib in adults who are inappropriate for intensive chemotherapy of the ALIA type patient population. The second is a cooperative group run through the NCI that I've been fortunate to lead, that is a randomized study that is aza-ven versus aza-ven-gilt, with the gilt given in two different dosing strategies. So we're very interested in that data and building upon the single center experience of MD Anderson, which I think is very encouraging. In terms of relapsed disease, we did a study with gilteritinib and venetoclax for relapsed patients that now a handful of years ago was published in Blood. And we think it was not randomized, but we think that kind of qualitatively the responses were deeper and their duration of response was better, though it's challenging to use these agents in terms of myelosuppression. And so we tried to provide some guidance in that article as well.
Thank you. Thanks a lot.
Thank you so much. Before the time is up, I really want to ask you, Dr. Jessica, your experience of FLT3 inhibitor, anyone in extramedullary relapse?
Yeah, so great question. We have had this is a rare setting where there's extramedullary relapse alone, and patients with FLT3 mutated disease generally, we also see marrow involvement. But we have utilized for individuals with mutations, we have used targeted agents, whether IDH FLT3 for the approved therapies, and we have seen success. If the individual at my institution, if the individual is able to tolerate chemotherapy in addition to a targeted therapy, depending on the location of the extramedullary disease, and hypothetical that I probably would give some cytarabine, at least intermediate or higher dose cytarabine to get at the extramedullary disease, depending on the location.
Any experience of using gilteritinib in extramedullary relapse?
Yeah, so we have used gilteritinib in folks who have had extramedullary relapse with responses.
Single agent? Or do you have?
We have used patients with skin involvement. So my guy Ray, who I presented, the one who was on 20 milligrams of gilteritinib in the phase 1 study, had some extramedullary skin involvement and responded with single agent treatment.
Thank you so much. Thank you so much for sharing. Next question, next slide, please. So we already have discussed even the real scenario of treatment emergent adverse events, so I don't want to discuss. The most common is transfusion dependency and neutropenia related infections, multiple, which even Indian patients are getting a lot. Next, please. So this is the exposure of treatment, and we have seen that if chemotherapy group was compared with gilteritinib, the response rates are better with little adverse effects. Next slide, please. So what would be your further course of action in this case? If the patient becomes in remission, would we continue till the progression, or should we continue to reduce the dose of gilteritinib? Any other thing which you think in this patients with so much of comorbidities would help to give him a better life? Dr. Jessica?
Sorry, I want to make sure that I understand. So
patient had end-stage renal disease, diabetes, hypertension, and the condition is not good. The patient comes in remission with gilteritinib. So further course of action, what would be there? Would we try to reduce?
So in remission on gilteritinib with those comorbidities, if the patient is tolerating treatment and you don't think the comorbidities are worsening, I would continue, and I would continue at the same dose. However, if things change, as has been mentioned before, I'm comfortable with 80 milligram dosing. And I think we need a little bit more experience across other patient populations. Maybe at 40 milligrams dose, we're getting enough FLT3 inhibition and an Indian patient population. I just don't have that data.
Thank you. Right. So, Dr. Priyanshi, any comment?
I would like to continue the patient on 80 mg, if possible. But if the complications are happening, if cytopenias, grade 3, 4 cytopenias and other complications are happening, so in that case, I might reduce the dose to 40. But as soon as those complications are tackled with, I would again increase the dose to 80 mg. I would like to keep the patient on 80 mg dose.
Oh, great. Dr. Padmaja, any comment?
No, I think we have addressed these. So yeah, no.
Okay, great. So next slide, please. So yes, because of pancytopenia, neutropenic fever, patient has infection, we interrupted the gilteritinib. Next slide, please. And after that, would you prefer to restart and with same dose or any different? Dr. Padmaja, please.
Perhaps once the cytopenia settles, we'll restart at a slightly lower dose, 80 milligrams, and then follow up. Yeah.
Next slide, please. So yes, we started with the 80 mg this time, and we continued for 7 months, completed, and patient remained in remission. Next slide, please. So I'm not going for this transplantation status. Let me a quick. May I skip this slide? Can we skip? Yeah. Can we skip this also? So to summarize, this is just a review of the patient with so many of comorbidities, how to tackle them, how we have to, handle the side effects. So next slide, please. So this is the case which I'm discussed already, that this patient with 56-year-old who presented with AML at relapse time. Sorry, yeah. So the induction therapy was given, consolidation given, and then after 7 months of post-diagnosis, patient underwent HSCT. Engraftment was observed 13 days post HSCT. Next, after that, next slide, please. After that, patient developed chronic GVHD of skin, mouth, and eye on day 180. It improved with therapy for GVHD. And then the patient presented on some swellings over the chest and abdomen. He diagnosed as myeloid sarcoma, treated with the therapy. Next slide, please. So the patient present with extramedullary relapse with chronic GVHD. So we already discussed that we have, Dr. Jessica have some experience. Any of the members present here who have any experience in extramedullary relapse, please give your insight. Anyone, Dr. Tulika ma'am? You have any experience of extramedullary relapse post-transplant?
To ask Dr. Jessica.
Sure, ma'am. Dr. Jessica, please.
Sure. So this is first of all, before we go on to this case, I think you did an amazing job with your prior patient. Congratulations. Beautiful job. And with this patient now with extramedullary disease post-transplant, but donor chimerisms that are 100%, this is a patient that I would also offer gilteritinib to. It sounds like it's mostly kind of skin and soft tissue involvement, if I understood correctly from your description. And yes, we've seen this, and yes, patients respond to targeted therapies. It's very difficult for me to give you a percentage of response rate because of the rarity of the situation.
So how many patients with complete chimerism but FLT3 positivity you see in extramedullary relapse? It's very common or it's rare?
It's pretty rare. I mean, it also, I think, probably depends on the conditioning strategies that are utilized pre-transplant. And I have limited experience even at a pretty big transplant center, maybe a patient every handful of years with this situation.
Thank you. Next slide, please. So re-biopsy revealed that mutation is present. He started with gilteritinib. In between, the sepsis happens. It has to be interrupted and resumed as soon as patient was able to tolerate. Next slide, please. So just to get a little, your experience that how the tolerability you think the patient would have, the options, high intensity chemotherapy, low, azavan, midostaurin, sorafenib. What is your comment on this? Dr. Jessica, please.
Sure. I'd be interested in, I think it's Dr. Sarita who has a lot of transplant experience. So I think, some of this depends on the time since the transplant and certainly their comorbidities at the time. But in terms of tolerability, in terms of ranking, generally gilteritinib, I would say number one, maybe then midostaurin and sorafenib, then azaven, which I would call low intensity therapy, but you might have a different low intensity chemotherapy in mind, and then high intensity therapy in terms of general tolerability in the patient's post-transplant. And we are in a situation where we don't know which one is best.
Right. Dr. Sarita, can you comment on this as per your experience?
What we believe that the whatever amount of this chemotherapy we are going to give, they are going to produce some complications basically. So we give NK cell based therapy we give. So post transplantation, in most of the cases, we treat very differently. We usually try to avoid unless there is a relapse. So that's the thing. We don't give them the
Right.
maintenance like neither EZA nor midostaurin, neither sorafenib. One of our patient who was post-renal transplantation, he developed AML. We treated him even with the NK cell therapy. After 14 months, he relapsed. In that time, we did not do second transplantation. We go with the gilteritinib. So he is now 4-month post-transplantation, post-relapse. So he's doing good with gilteritinib. So that's the only
Yes.
we have experience.
Nice. So I think with all this discussion and the time is running out, I would say that gilteritinib is coming out to be a real boom for this relapse refractory settings
The
for
results are very
FSHD patients.
encouraging. Right, you're
Yeah,
absolutely
the
right.
results are good
Encouraging.
with, you're right. So great efficacy, minimal side effects, and the patient becomes a relatively early independent. That makes a real, our physician-friendly medicine. So thank you so much. I think with Tulika ma'am's permission, I think I want to wind up this because time is also alarming. And we have a great discussion. So thank you so much. Especially thanks to Dr. Jessica for being part of this and giving your insight. Thank you so much.
Yeah, thank you, Dr. Jessica.
Thanks to all of you. Thanks for including me, and I learned so much from each of you.
So back to Dr. Tulika.
So thank you very much. This has been an excellent discussion, and I think we've all learned so much from each other. There's a lot of more trials going on, and I think the Morpho trial and other trials are very important for us. Monitoring MRD is going to be very important post-transplant and in other situations. I think there's still a few questions to be answered, but we're definitely in a better position than we were a few years ago. And with that, I'd like to thank Dr. Jessica and all the participants and the panelists, and definitely all the audience who joined us. If you have any other questions that have remained unanswered, please do write to us. We'll try to get back to you on the questions, and back to the organizers for this wonderful platform.
Thank you very much, Dr. Tulika, and to all the esteemed faculty members who have joined us today. It was an academic fiesta for us. Thank you, Dr. Jessica, for your expert insights and for guiding us through, and for all the faculty members to be so interactive. We will definitely, maybe, ma'am, with your permission, we can share your email ID with a few HCPs who can reach out to you in case there are any more questions.
I would be honored if anyone reached out to me. Please do.
Thank you so much.
Thank you. Thank you, Dr. Tulika. Thank you, everyone.
Thank you.
Thank
Good
you.
night.
Good night. Thank you.
Good night,
Bye.
everyone. Thank you.